I'm Dr. Leslie Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York. Bipolar depression is often misdiagnosed as major depressive disorder. That's because the episodes of major depression that can occur in someone with bipolar disorder looks identical on cross-section to someone who has major depressive disorder. So the episodes themselves are identical. What's different between major depressive disorder and bipolar disorder is the prior history of mania or hypomania. So that's the chief distinguishing feature. Unfortunately, the treatment of major depressive disorder and bipolar disorder is quite different. So if we treat a major depressive episode the same way as we do for bipolar, as we do for MDD, we're going to get into trouble. So, for example, antidepressants are often used to treat major depressive episodes that are associated with major depressive disorder. And that's fine. These drugs work in that disease. We use them for years, and they're predictable. However, antidepressants used in bipolar depression, that is, major depressive episodes associated with bipolar disorder, these antidepressants don't necessarily work. If they do have an effect, they can be very short in terms of their beneficial effect, and you run the risk of inducing mania or hypomania in these patients. Well, the evidence base for bipolar depression is heavily dependent on drugs such as second-generation antipsychotics and some data regarding mood stabilizers. In the United States, there are 3 agents approved for the treatment of bipolar depression. These include quetiapine, olanzapine fluoxetine combination, and lurasidone. These are the 3 agents that are approved to treat bipolar depression, that is, major depressive episodes associated with bipolar disorder. No antidepressant is approved for this purpose, and no anticonvulsant or mood stabilizer is approved for this purpose. Amongst the 3 choices that are approved in the U.S. by the FDA for the treatment of bipolar depression, lurasidone, quetiapine, and olanzapine fluoxetine combination, they're all quite different in terms of their tolerability profile. They all work, they're all very similar in terms of efficacy, but tolerability is different. So for example, olanzapine fluoxetine combination is associated with a risk for weight gain and metabolic abnormalities. Quetiapine is associated with a risk of sedation. Lurasidone seems to be well tolerated. There is a risk of akathisia, for example, but there is no risk of excessive sedation that you would see with quetiapine, and the metabolic profile is very clean with lurasidone, so you don't necessarily expect weight gain or metabolic abnormalities. Lurasidone's mechanism of action is similar to that of other second-generation antipsychotics, but there are some subtle differences in binding affinities for some of the other receptors, such as serotonin 5-HT7, for example. Whether this translates to different effects in humans is unclear, but it does make for a different medication. In terms of efficacy, we have evidence of good efficacy in the treatment of bipolar depression, for example, with lurasidone, but again, the tolerability profile differs from that of the other choices. We don't see the weight gain that we would ordinarily see with other second-generation antipsychotics, and we don't see the degree of sedation that can be seen with some of the others as well. In terms of safety issues, the product labeling for lurasidone in the United States contains very similar warnings and precautions with that of other agents. However, metabolically, the evidence points to a somewhat lower risk for abnormalities. There is no prolongation of the QT interval. So I would say the primary adverse events of concern that can occur that I warn patients about and then I look for would be things like akathisia or nausea, principally. But then again, these are different issues than what was seen with the other agents. It depends on the individual person on how sensitive they are to side effects in general, but overall, a highly tolerable drug. Well, the most important point I can make is that we need to avoid antidepressant monotherapy in patients who have bipolar depression. So probably that the biggest impact that we can make by communicating this information is to make sure that we have a differential diagnosis that is accurate. And so getting information from family members is really important to find out if there was a history of mania or hypomania that the patient themselves are unable to articulate or report. By making a careful differential diagnosis and ruling out other disorders and making sure that you know what type of depression someone has, that'll dictate the choice of the intervention. And we know that antidepressant monotherapy is not helpful for patients with bipolar depression, whereas other agents are very helpful. And in the US, again, as I mentioned earlier, 3 agents are available for the treatment of bipolar depression. They include lurasidone, olanzapine fluoxetine combination, and quetiapine. Sometimes I'm asked about lamotrigine, whether that's an option for the treatment of bipolar depression. In the United States, lamotrigine is approved for the maintenance treatment of someone with bipolar disorder. It did not get approval for the treatment of major depressive episodes associated with bipolar disorder because the effect size was small. Not to say that it doesn't work, but it doesn't work as often as the choices that are approved.